Yeah.
So Gideon, are you ready? Can I introduce you now?
Yes, please, I'm ready.
Yeah, okay. Okay, our next speaker, the second speaker, is Dr. Gideon Gabriel Malwa. Dr. Malwa is a consultant physician in diabetes and endocrinology at Queen's Hospital at Romford in East London, here in United Kingdom. Dr. Malwa is actually our brother from Tanzania, and he's a founder member of Tanzanian UK Healthcare Diaspora Association, which is, sort of truncated as TUHIDA. Dr. Malwa obtained his medical degrees from Crescent University in Bulgaria in 1997. But he did his specialist training here in the United Kingdom with the London and Wessex Deaneries, where he specialized in diabetes and endocrinology within the internal medicine. Dr. Malwa trained in all aspects of diabetes, including all those complex technologies such as insulin pump used in the treatment of diabetes. So he's well equipped. So this is the kind of skill that we need among the diaspora. Dr. Malwa's passion actually is in medical education, where he believes that medical education is a continuous and ongoing process. Medical education never stops. I remember one time a professor of medicine was asked, when do you stop learning in the medical profession? And he replied, 10 minutes after death. So Dr. Malwa today will give us a lecture on diabetes mellitus, and we hope that it will give us some insight into why we, the Black, Asian, and ethnic minorities, have more than our fair share of this disease, and how this disease and its burden, which is very heavy, gives the outcome in COVID-19. Dr. Malwa.
So thank you very much for your kind introduction. I think the host, you have to make me a co-host so that I'm able to share my slides. I can't share my slides without being co-host. Let me try.
James,
No, you can do it straight away.
Do it now.
Let me try.
Share the screen. That should be that green screen share.
Green.
Yeah. Can you see my slides now?
Yes.
Oh,
yes.
yeah. Now go into slideshow now.
That's it, yeah.
That's it. We are running. Yep.
So thank you very much for your kind introduction. And my name is Dr. Gideon Malwa. I'm based at Queen's Hospital, Romford in East London. And I'm sorry I'm on my scrubs because I'm on call today. And in today's talk, I'm going to talk about diabetes and you. And as part of the talk, I'm standing here as a part of East African diaspora community to head as a member, founding member, and also as a treasurer. So I'll talk about both type 1 and type 2 diabetes in short, in terms of definition, but also I'll talk about the complications of both type 1 and type 2 diabetes and how we manage them. Most importantly, in the light of pandemic and of COVID-19, we're going to talk about diabetes and COVID-19, but in short, in terms of what is special about having comorbidities such as diabetes and the COVID-19 in terms of outcome for patients with COVID-19. And I've looked after a lot of patients during COVID pandemic throughout the first wave and now the second wave in front line. So when you define diabetes, it's just a chronic condition whereby there's persistent high sugar levels for a long time. And if I take a figure of a sugar level more than 6 fasting sugar level and more than 8 after 2 hours of eating, that can be a sign of somebody having diabetes. And we know that in patients with diabetes, they don't produce enough hormone called insulin, which is a very important hormone, which is produced in the pancreas. And with that, the function of insulin hormone is to transport glucose within the cells to be used as a source of energy. So for different parts of the body or cells to use glucose as a source of energy, you need insulin as a key to open the cells for the sugar level, for the sugars to go through the cells and be utilized as a source of energy. So the lack of insulin or inability of insulin of the body's response to insulin can cause high sugar levels or hyperglycemia. And if you get high sugar levels for a long time, that can lead to complications, which I'll be talking later in my next few slides. So this slide just summarizes what is the current state of diabetes worldwide. We've got over 460 million people with diabetes living in the world, and that number will go up to over 700 million by 2045. In Africa alone, we've got about 20 million people living with diabetes, and that number will go up to over almost 47 million by 2045. In the UK, we've got about 4 million people living with diabetes. And if you look at this slide, it tells you that diabetes is a big problem, not only within the UK, but worldwide. So this slide just summarizes and repeats what I've just told you in terms of prevalence of diabetes worldwide in different parts of the world, in terms of continent by continent or country by country. So let us talk about type 1 diabetes as a condition. It belongs to a group of conditions called autoimmune conditions. And in this case, patient with type 1 diabetes is due to defective immune system, whereby the body incorrectly identifies part of the body as foreign, in this case, beta cells, leading to destruction of beta cells, and with that, less production of insulin or lack of insulin altogether, causing hyperglycemia and therefore type 1 diabetes. But there are other contributing factors. So when we talk about type 1 diabetes, we talk about genetic contribution, that people with who have got a genetic component of type 1 diabetes, but also we get the so-called environmental contribution of the so-called initiators or accelerators of type 1 diabetes. You get triggers such as viruses, which can cause diabetes, but also some sort of toxins, which can be toxic to beta cells, can cause destruction of beta cells, and therefore lack of insulin production, and therefore leading to hyperglycemia and the type 1 diabetes. One cannot ignore the role of bad diet in terms of making diabetes worse, and therefore dietary factors contribute to type 1 diabetes. Talking about the genetics, it's a busy slide, but I'm going to pick this number 3 part of this slide, saying that if both the mother and father they are diabetic, the risk of the siblings to get diabetes goes up by 30%. So genetics is important in terms of contributing to type 1 diabetes. What about environmental factors? When we talk about environmental factors, the far you are from the equator, you're more likely to get type 1 diabetes. The explanation may be due to the fact that these countries which are very far away from the equator, they've got different climate in terms it's not very warm, and therefore there are a lot of viral infections. And we said that as a contributing factor or trigger for type 1 diabetes is viral infections. So the far away from the equator, you are more likely to have type 1 diabetes. That's environmental factor as a contributing factor to type 1 diabetes. What about other triggers such as viral infections, but also low levels of vitamin D? Dr. Christopher talked about the role of vitamin D in terms of mental health, but also for diabetes, we know that vitamin D is a hormone, is an immunomodulator, and therefore lack of vitamin D can lead to diabetes in this sense, because for the formation of insulin, somehow you need vitamin D as immunomodulator. And in other patients, you get increased insulin demand, and therefore they can get type 1 diabetes. But I talked about the role of different types of toxins which can attack the beta cells and therefore causing diabetes in these patients. So talking about vitamin D, there was a study called the Euro Diabetes Study, which showed that there was high levels of, or high prevalence or incidence of people with type 1 diabetes, but also those who had low vitamin D. So we know that supplementation of vitamin D, therefore, can be a protective factor in terms of preventing type 1 diabetes. So low vitamin D can contribute or somehow contribute to type 1 diabetes by the fact that vitamin D is a hormone and is an immunomodulator. So in those people living away from the equator, they've got low levels of vitamin D, especially those with black skin, African and Asians, because there's a lack of sunlight in these countries, especially away from the equator, whereby the sunlight is limited for a few months in a year. And Dr. Christopher talked about where are the source of vitamin D. One of them is from nutrition, but also the sunlight is a source of vitamin D, whereby you get from sunlight, you get different mechanisms by which vitamin D, active form of vitamin D is formed to be able to function and to help people absorb different nutrition. So we know that there's an association between type 1 diabetes and different viruses. And in mothers who are pregnant and they had high levels of antibodies titers of enterovirus, their children went on to develop type 1 diabetes. That's a link between viral infection and type 1 diabetes. So what about diet? We talked about different types of diet. In this case, we're talking about the bad diet. There's the so-called high glycemic index food, which can contribute, or there will be the accelerators or initiators of type 1 diabetes. So the importance of good diet in this slide is important, that high GI index food can cause or contribute to accelerating diabetes. And this is type 1 diabetes. So this slide just summarizes what I've just told you in terms of contributing factor. We talk about genetics, we talk about other autoimmune conditions which can contribute to type 1 diabetes, but about viral infection and direct destruction to beta cells through maybe infection or other toxins can contribute to type 1 diabetes. But also, if you get somebody who has got problem with their pancreas and they've underwent surgery, the removal of pancreas can lead to type 1 diabetes in this case. And one cannot ignore the environmental factor. All of these are contributing to type 1 diabetes. So I think in type 1 diabetes patient, they can develop type 1 diabetes at any age, but it's more common in younger patients and adolescents. But we tend to get older patients who we are diagnosing them with type 1 diabetes, but they fall under a different group, which is called latent autoimmune diabetes of adults, or LADA, and they need insulin. So the take-home message from this slide is that the type 1 diabetes patient, they need insulin lifelong, and you cannot stop taking insulin once you are type 1 diabetes, simply because if you stop taking insulin, there are complications with regard to that. You get acute complications such as diabetes, ketoacidosis, or chronic complications such as nephropathy, retinopathy, and peripheral neuropathy, in this case due to diabetes, which I'll be talking in the next few slides. And in terms of what are symptoms of type 1 diabetes, most patients will complain about being very thirsty and passing a lot of water. So it's also termed as polyuria or polydipsia, being more thirsty, going to toilet more often, lack of energy, and weight loss. It can be a feature of type 1 diabetes. I remember back home when we were little or children, in a child who has got bedwetting, it can be a sign of type 1 diabetes, and therefore it's very important for families that if they've got a child who is bedwetting, can this be a sign of type 1 diabetes, and they need to be checked, not to be punished. So these slides are just summarized in terms of symptoms of type 1 diabetes, that you get frequent urination, weight loss, lack of energy, and excessive thirsty as the features of type 1 diabetes, and therefore one should check their diabetes or sugar level or seek help if they've got those features or symptoms of weight loss, passing urine more than normal, lack of energy, or being more thirsty. And for children, if they've got these features of symptoms of bedwetting at night. The treatment for type 1 diabetes, I've just told you that is insulin, and that is a lifelong condition. We have got other technology to support treatment of type 1 diabetes, but the most important message from this short talk is about making sure that if you are type 1 diabetes, you need to take your insulin lifelong, and don't miss doses, because you end up having complication of type 1 diabetes or of diabetes altogether, being acute complications such as diabetes ketoacidosis, which can be life-threatening, and the chronic complications, which I'll be talking in the next few slides. So what about type 2 diabetes? I've talked about type 1 diabetes as common among children, adolescents, but now we're getting type 1 diabetes in some adult patients. But talking about type 2 diabetes is a common type of diabetes. It contributes or accounts for 90% of all diabetes cases in the world. In these patients, they produce some insulin, but that insulin is not enough due to the so-called insulin resistance. So type 2 diabetes patients, they're able to produce insulin, but they've got the so-called insulin resistance, and therefore the body is not able to utilize the glucose. The sugar level remains high, and the excessive sugar is stored in the fat. They feel more hungry, and they eat more, maybe bad diet, and that's a vicious cycle, and it's an ongoing problem. So in type 2 diabetes patient, it's common in adults, but we are getting younger patients with type 2 diabetes because of change in lifestyle. We are getting younger patients who are more obese. They're eating unhealthy food, and therefore they're getting type 2 diabetes, even if they're young. So this is just to repeat what I've just told you in terms of type 2 diabetes patients. But let us talk about genetics in type 2 diabetes. So in type 2 diabetes, genetics is one of the contributing factors. So I'm going to pick a number 2 in terms of this slide, just point number 2. If both mother and father have got diabetes, type 2 diabetes, the siblings, the children are more likely to get type diabetes. Is more than 75%. So genetics plays a role in type 2 diabetes as well, but it's more important compared to type 1 diabetes. So this slide just summarizes what are the contributing factors to, for type 2 diabetes. On the left-hand side of the screen is non-modifiable risk factors. On the right side are modifiable risk factors, namely lack of exercise, being overweight, having high blood pressure, having high cholesterol. So if you look at the right-hand side where you get modifiable risk factors, it means that we are able to do something about this to reduce the risk of getting type 2 diabetes. So lack of exercise, high blood pressure, being overweight are modifiable risk factors for type 2 diabetes. On the left-hand side, there are non-modifiable risk factors in this case. If you have got a family history of diabetes, you cannot change the genetics. So genetic contribution, you're going to change it. If you're older, age of more than 45 years old, you're at risk of getting type 2 diabetes. You cannot change your age. You got to modify that. So we know that type 2 diabetes is more common in among ethnic minority, Afro-Caribbean, Asians. We know this is a fact in UK and especially in London, but also in patients who had gestational diabetes or diabetes during pregnancy for women, they've got a risk of getting type 2 diabetes by 50%. So having gestational diabetes, being of ethnic minority background, age over 45 years old, and family history of diabetes are non-modifiable risk factors which are contributing to type 2 diabetes. So these are just summarize the modifiable risk factors which I've just told you that if you've got high blood pressure, it contributes to type 2 diabetes, and therefore controlling the blood pressure is helpful. If you're a smoker, it's contributing to type 2 diabetes, and therefore if you stop smoking, that will help to reduce risk of getting type 2 diabetes. What about lack of exercise? So doing exercise, it helps in different ways. One, it increases insulin sensitivity. Two, it reduces blood pressure. When you lose weight, you get better diabetes control. You get lower level of bad cholesterol, the so-called LDL cholesterol. But if you're overweight, you lose your weight, you get better diabetes control, and also you reduce the blood pressure. And what about if you eat better diet, you reduce everything in terms of contributing to type 2 diabetes. So these slides just summarize the modifiable risk factors, which at least you can do something about modifiable risk factors to try and avoid type 2 diabetes. So we know that type 2 diabetes is seen in older patients, older individuals, but we are getting type 2 diabetes in younger patients. We are getting a changing face of type 2 diabetes in younger patients because of lack of exercise, because the younger patients are eating junky food, because younger patients are obese, they are overweight. So we talked about the symptoms of type 1 diabetes. The symptoms of type 2 diabetes are almost or less similar to those of type 1 diabetes. That patient will have increased thirsty, they will pass a lot of water, maybe vision will be very poor, and if they get any wound or an ulcer within the foot or hands, it takes longer to heal. So that can be a sign of diabetes. But we talked about in younger patients, in children, if they're relatively young, if they start having bedwetting habit, it can be a sign of diabetes, and therefore a parent or a mother or a caretaker of these children, they have to check for diabetes. And the onset of type 2 diabetes is usually very slow. That's the difference between type 1 diabetes. The onset is very quick. It's a matter of weeks and not months. But type 2 diabetes can take months up to a year for someone to know that they've got type 2 diabetes, because the symptoms are very slow, and therefore one can be delayed in terms of getting diagnosis. So this slide just summarizes what are the symptoms of type 2 diabetes. You get blurring of the vision, you get easy infections such as fungal infection or genitourinary infection of the so-called UTIs, unexplained weight loss, but sometimes people can just complain numbness to the feet. But if they've got wounds or any ulcer, it's slow healing wounds. And therefore one has to ask themselves that if I get a wound which is slow healing, can this be diabetes, in this case type 2 diabetes? So I've just touched in both type 1 and type 2 diabetes, but let me talk about the complications of both type 1 and type 2 diabetes. So we know the complication can be that of heart diseases, but also it can affect the kidneys, the so-called nephropathy. But it can affect the nerves to the feet, causing neuropathy. And diabetes is the leading cause of blindness at least in the Western world, in the global North. And we know that diabetes is the #1 cause of kidney failure in Western world. If you get diabetes, you can have slow healing wounds and get complications leading to diabetic foot ulcers. And if it's severe infection, it can lead to osteomyelitis and therefore leading to amputations. So some patients with very poorly controlled diabetes, whether it's type 1 or type 2 diabetes, unfortunately, they end up having bad chronic foot ulcers, leading to osteomyelitis, leading to recurrent infections, and therefore needing amputations. So this slide just summarizes what I've just told you in terms of it can cause blindness, retinopathy, it can cause heart problems or ischemic heart disease, it can cause kidney problems. So we know that diabetes is the #1 cause of kidney failure in the Western world, at least. And then you can cause nerve damage to both hands and feet. And some people with diabetes can have bad teeth or tooth decay, leading to complications and infections. And what about the cause of strokes? So we know that with diabetes, you get narrowing of blood vessels, and that can lead to both heart attacks and strokes as a complication of diabetes. So those patients who are diabetic, they are at much higher risk of getting either heart attack or strokes because of diabetes. And therefore, managing or controlling their diabetes is vital and important to avoid those complications. So this is just much the same of what I've just told you in terms of the complication of diabetes being stroke, heart attack, peripheral neuropathy. You can have cataract. Some people get retinopathy because of bleeding behind the eyes, and the so-called nephropathy, which is kidney problems. So let me talk about the management of diabetes, because in terms of managing diabetes, we've seen the contributing factors. Some of them are modifiable and some of them are not modifiable. So I'm going to concentrate on those modifiable risk factors in terms of the role of balanced diet. So healthy diet helps in terms of getting better diabetes control and therefore reducing complications. This is not an example of a healthy diet, so I'm trying to insist in terms of saying that avoid unhealthy diet. This individual who is eating a lot of chips is rich in carbohydrate, and therefore maybe it's too much for that. It's one example of high glycemic index food, which can contribute to high blood sugar levels, but it can contribute to obesity and therefore high blood pressure, high cholesterol, especially the LDL cholesterol, and the risk of getting heart attack and strokes. So what about exercise? So doing exercise at least 30 minutes per day, brisk walk is enough. If you're able to run, if you're able to go to the gym, that can help in terms of management of diabetes. Exercise has got two effects. #1, exercise increases insulin sensitivity. By doing that, it helps the muscle to utilize sugar levels within the blood and therefore reduce the sugar levels. But also when you exercise, you reduce the so-called bad cholesterol, which is LDL cholesterol. So it's very beneficial. When you exercise regularly, you lose weight. And by losing weight, well, if you lose 1 kilogram, the blood pressure goes down by about 10 millimeters of mercury. So the take-home message is exercise helps in terms of both better diabetes control, better blood pressure control, and therefore weight loss, and therefore better cholesterol control, especially the bad cholesterol, the so-called LDL cholesterol. So this slide just summarizes what I've just told you in terms of what is the role of exercise in terms of improving diabetes, improving sugar level, and reducing the so-called bad cholesterol. So the managing type 2 diabetes is a combination. So we said initially you look at lifestyle modification, looking to try and modify the modifiable risk factors, which I've just mentioned. And if that does not improve with your diabetes, we start with medical therapy, which will be in the form of tablets, but also some of the patients who are type 2 diabetes for many years, unfortunately, eventually they end up taking insulin. So they can be given insulin. So they can have be both tablets or injections as part of the treatment of type 2 diabetes. But most importantly, you try and modify the risk factors first by having healthy diet, exercise, reducing other risk factors such as blood pressure, and by doing that, you can help manage your diabetes. So we cannot stop talking about diabetes and technology. So for both type 1 and type 2 diabetes, we have got technologies which are helping to treat patients with diabetes. So in this case, we can use artificial pancreas or the so-called insulin pump. It's an example of artificial pancreas, but it's not a complete artificial pancreas because you still need an individual to operate the pump. So we use insulin pump in both type 1 and type 2 diabetes, but most often in type 1 diabetes with poorly controlled type 1 diabetes and those who are getting recurrent, disabling, unpredictable hypoglycemia. And therefore that affects their quality of life. And in my clinic here, I've got few patients who have put on insulin pump. So we are getting patients who are using technology for their diabetes to support their management and therefore improve their quality of life. And most recently, we've got a so-called flash glucose monitoring or freestyle Libra, which is just, you attach the sensor to under the skin, and from that, every 15 minutes, you get a reading of glucose levels. We use this in patients with poorly controlled diabetes, but also there are patients who are diabetic. For both type 1 and type 2 diabetes patients, if they are taking insulin or some of the tablets which can lower their glucose level, they need to monitor their sugar level all the time. So an example I'll give you that a diabetic patient who is type 1, they need to monitor their sugar level by pricking themselves at least 6 times a day. And that's a lot. It's a lot in terms of causing pain. And some patients, they are needlephobic. And some patients with that, it affects their quality of life. And some of them are poor compliant because of that. And therefore, having a technology such as Freestyle Libra, it makes life easier for patients. It's user-friendly and it's easier to use. So I was told by Dr. Peter Julu not to touch COVID-19 and diabetes. So diabetes patients are part of the group of people who are at risk in terms of getting complications if they get any infection, including COVID-19. I've been in front line during the first wave of COVID-19, looking after different types of patients, including diabetic patients, and therefore our diabetes patients were doing badly in terms of their COVID complication. The majority of patients who went to HDU, ITU were diabetic, but other risk factors who I saw in terms of group of patients who I reviewed and during COVID-19 are those who are overweight, those patients who have got cancer and they're on chemotherapy or immunotherapy, those with other comorbidities such as heart failure or hypertension. So coming back to diabetes, why type 1 diabetes, why diabetic patients are at high risk of getting complications if they get any sort of infection, including COVID-19. For COVID-19, if you look at the COVID-19 virus, it has got spike proteins. And the receptors for spike proteins are within, they're called S2 receptors. You've got high numbers of S2 receptors in beta cells of the pancreas. So one mechanism by which we think that the diabetes patient did badly when they had COVID-19 is because the COVID-19 virus had direct toxicity to the beta cells through the S2 receptors, which are rich, or there are higher numbers of them in beta cells. That's one explanation. But if you take diabetes as a chronic condition, is the patient with diabetes, they're in a state of chronic inflammation. And if you look at the pathophysiology of COVID-19, the postulated pathophysiology of COVID-19 was one of the mechanisms was that in COVID-19, there's high levels of cytokine storms causing inflammation. And therefore, patients are becoming very unwell. So for these patients who have got diabetes, they've got a chronic inflammation anyway, and therefore they're at risk. The patient with diabetes, they're immunocompromised, and therefore their immune system is not 100%, therefore they're at risk of getting infection, including COVID-19. And also, during COVID-19, patients with diabetes, if they come, they're unwell, most of them, they'll be dehydrated, they will be in acute kidney injury, and therefore, when you manage them for COVID-19, you have to manage their diabetes correctly. And if these patients were type 2 diabetes, they are on medication which can cause kidney problems such as metformin. We had to stop those medications for short term and then maybe use insulin, manage their diabetes properly for the infection to get better. So COVID-19 and diabetes is important in this aspect that diabetes patients are part of the group which we saw, the so-called risk groups. And we have seen in the first wave of COVID-19 that most patients who went to HDU or ITU had either diabetes, they had other comorbidities, including obesity, hypertension, or they were cancer patients. So in summary, we've talked about both type 1 and type 2 diabetes. We talked about the complications of both type 1 and type 2 diabetes. We talked about the contributing factors, and most importantly, the modifiable risk factors. I think that's it. I want people to take this home as a message that you can modify the risk factors and therefore avoid getting diabetes, or if you've got diabetes, to try to make sure that your diabetes is controlled. But also I've touched about the role of diabetes as chronic condition, as risk factor for worse prognosis or doing badly if you get COVID-19. And the management of diabetes patients is not a one-man or one-person task. So I cannot insist enough the role of the multidisciplinary team. And my team is made up of dietitians, diabetes nurses, family members of the patient, because they're important, and of course the doctors. And I will say that I want you to stay safe and look after yourself. We are in the second wave of COVID-19, and those patients who are diabetic, they have to make sure that they take their medication regularly. They have to make sure that they're in touch with their healthcare professionals to get support. And if they come to hospital, they will be looked after by a diabetes team, including myself. I'm a member of Diabetes UK, and I do charity. And in 2017, I did the London Bridge Challenge, where I walked through the 12 London bridges. And I will encourage you to support Diabetes UK, because they do a lot of research. Thank you very much.
Yeah, thank you very much indeed. You can now take off your screen share, Dr. Gideon.
Where do I go? Do I just stop?
Stop screen share on the top. Yeah, okay. There we are, okay. Now, okay, Dr. Gideon is actually, Dr. Malwa, is actually on call. So, so we really do need to ask questions which we think he can answer very quickly first before we can then revert to the normal programs of answers and questions. So if the panel, if the participants do have some kind of questions which they want to address directly to Dr. Malwa, let them do it now, because he's on call. He could easily be called at any time now. And he's
I'm happy to give another 20 minutes.
Yeah, oh yeah, you have another 20 minutes. So, okay, that's good. And also, we have His Excellency, our High Commissioner here, whom I've asked him actually if he could just say 1 or 2 words after Gideon's questions, and also Moses, the head of UK Alliance, UK Health Alliance here, also another 1 word. This is just because we are actually working in partnership with all these groups, and these are very important people as far as our DHSP organization is concerned. So, James, do you have very urgent questions? I have seen from Botswana a question by Dr. Nen that is talking about ketosis. Could you elaborate, please, on ketosis?
Yes, can I go? Yeah. Can
Yes.
I?
Yeah, you can go ahead, yeah.
So when we talked about the complication of diabetes, especially for type 1, so we separate complication as acute and chronic. The acute complication for type 1 diabetes, an individual can build up acids. So it's called diabetes ketoacidosis, or DKA. So it means they've got high sugar level. Because they've got high sugar levels and they don't have insulin, the body is not able to use the sugar. The body is rich in sugar, but it's not able to use it. But the cells or part of the body cannot stay longer without having another source of energy. So the way the body is programmed is that it starts breaking down fats and the protein. So you break down fats, you get free fat acids, and therefore from that you get ketones, and therefore this is called diabetes ketoacidosis. I tried maybe to explain that in a simple term, but it's...
I on camera, John. Why? Yeah.
So the ketosis or diabetes ketoacidosis, it is a complication of type 1 diabetes, and I'm going to repeat it, is that in these patients with type 1 diabetes, they have got high levels of sugar, but they're not able to use it because there's no insulin, but the body cannot starve for longer. And therefore, instead of using the sugar, you start using alternative source of energy by breaking down fats. The fat is broken into free fatty acids, and from free fatty acids, you get ketones, and therefore diabetic ketoacidosis. And these patients can be very sick, and it's a life-threatening condition. So I've got my patient today who came yesterday with diabetes ketoacidosis for different reasons, and therefore they need to be well treated to get a better recovery. I hope I've tried to answer the question.
Dugu, can I ask Dugu a question? This is something that I've asked already yesterday. Was the question I have is whether we are moving away from the pinprick for monitoring glucose to something much more less invasive, because a lot of people are very afraid of having to prick themselves, to monitor glucose.
So, can I go on this? Yeah?
Yeah.
So, I talked about diabetes and technology because it's part of this. I think as the advance in technology has seen us trying to use technology to treat diabetes and other conditions. So the history of insulin pump was from 1986. We had the first insulin pump. Then as we went along, we get more and more technologies coming. But to use technology is not for every patient will be able to benefit from technology. Because if you want to use insulin pump for a type 1 diabetes patient, they have to know how to count carbohydrate. So they have to have a basic knowledge of arithmetics. So if they are not able to count, then they will not benefit from technology. That's number one. Number two, you give a technology to any individual who is type 1, they have to be able to engage with technology, otherwise they will not benefit. So yes, we would like to give technology to every patient who is suitable for that, but they have to be able to engage. So when we are using insulin pump, for example, one pump, the pump itself is 3,000 pounds, a pump, okay? Then you get consumables, the tubing and everything every month is different cost. So it's a lot of money. So in this country, in UK, we are guided by NICE, which is National Institute for Health and Clinical Excellence, in terms of trying to choose which patients can be given pump. So the indication for insulin pump in UK for type 1 or type 2 diabetes patient, there are two main indications. One, the patient who are getting disabling severe hypoglycemia, causing anxiety and poor quality of life, or poor diabetes control. That's why we get a few patients on insulin pump, some of them are not. But talking about the flash glucose monitoring, the Freestyle Libra, yes, a lot of patients were giving it to them, to both type 1 and type 2 diabetes, just for the purpose of monitoring. So in summary, yes, we are moving away from using pinprick to using technology to improve patient care and transform their lives, but with enough support, but also it has to be both ways. The patients have to engage.
That may be a call now. I mean,
No, I'm okay. Carry on.
Just before you.
Meeting, can I call you? I'll call you after 10 minutes.
Just before you disappear as well, I think there was one of the participants who had asked, can you get insulin pump from the counter? I think you have answered some of the question already.
So in terms of this, because if you want to initiate, so for insulin pump, at least in UK, you have to have an insulin pump team, which is made up of dietitian, diabetes nurses, and doctors. So it means there's a team looking after patients who are on insulin pump, because this team is responsible to offer structured education. Our pump patient, before they go into pump, they undergo carbohydrate counting course, which is 5 days course. I've done the course. I'm not diabetic, but I joined the group of patients to do the course for 5 days so that I know what they go through in terms of the meaning of carbohydrate counting course. So once they're able to go on that, then they'll be able to be offered insulin pump. So the answer is you can't get insulin pump over the counter.
Yes, James, do you have any more questions from the participants?
Yes. If insulin transports glucose to the cell in the body, does that mean that if you have low insulin, there's glucose transported to the brain?
So with that, in terms of when we talk about the cells being able to use insulin, I'll simplify in this way. I will say that the insulin is the key. You have to open the cells for the sugar to go inside the cells. So without insulin, that door will not be open. I'm trying to simplify the mechanism of transport in terms of trying to transport glucose within the cells. So when there's no insulin, there will be no transportation of glucose within the cells. So the insulin is like a key to open the cells for sugar to go inside the cells. In terms of going to the brain, I didn't get the question. What was the question?
James.
Yes, the question is this: if insulin transports glucose to the cell in the body, does that mean that if you have low insulin, there's less glucose transported to the brain?
Yeah, that's it.
I could help you probably there, but anyway, go ahead, Gideon.
So in terms of that, we know that the part of the brain is the most important organ. Brain, heart, and the kidneys. There's a brain-blood barrier, which is different from that. I think that the metabolism of insulin within the brain is slightly different from other part of the body. But if you become better and well with building acids or ketosis in the body, people can come with manifestation of being in coma because of that.
Yeah. Yes. Just to add on what Gideon is saying is that as a neurophysiologist, we know that part of the problem with diabetes is that the nervous system gets drunk with the sugar, because they do not require, insulin in order to get sugar. They are treated as special tissues by the body, by God. I would tell my patient that they're treated as special tissues, that they don't need permission from insulin to get glucose. But unfortunately, when other people are now not getting it, and they are the only tissues that are getting it, they get too much of it. And unfortunately, that gives problem to the nervous system, and that is my PhD actually, is neuropathy in diabetes, the complication. That is the biggest problem, and actually that is also part of the biggest killer, as far as complication with diabetes is concerned. You cannot escape that. That's the unfortunate bit. You don't need insulin for the nervous system to get sugar. And unfortunately, they get drunk with it.
Now, what are the cost implications of treatment for patients with diabetic conditions in the UK?
Complications.
Yes, the cost implications of treatment for patients with diabetic conditions.
I'm not a health economics, but in terms of, we know that it's a chronic condition. It takes, I think, bigger part of the budget within the NHS, and therefore making sure that, so I'll give you an example of, if a patient comes with high sugar, DKA, or low sugar as a complication of part of diabetes, one overnight hospital stay is £700. So an average stay for a patient who comes very unwell with infection with diabetes might stay 3 to 4 days. So that's an example. But I know that diabetes as a chronic condition takes the biggest chunk of NHS budget, not only within the hospital, but also in the community. Maybe Dr. Aslam can help me.
Yeah, I mean, the figures normally waved around at us when we are doing applications for grant is about 3.8 billion pounds. This is only in England, but not even the whole of UK yet, you see. So it's a big cost. And the complication of diabetes alone is even bigger. The cost is bigger than the 3.8. The 3.8 is mainly to maintain the GPs giving the prescription and the rest of it. And then when it comes to the getting the complication, the various complications of diabetes, then the cost really goes right to the roof.
Yeah, just a little comment from me, really, before Gideon has to run away. You touch on pregnancy. Gone are the days when one of the early symptoms of potential diabetes type 2 is microsomic baby, women giving birth to very heavy babies, and that which could be the first symptom that there is a potential for diabetes later in life. But the good thing is, in the UK now, every woman actually gets tested for diabetes on presentation of pregnancy. I wonder if any of my brethren participating from abroad, whether there is universal checking for diabetes in pregnant women, both in East Africa, say Tanzania and Uganda, for people who are listening from there. Number two, we now know that vitamin D supplementation actually does delay or reduce the onset of type 1 diabetes. Now, as a GP, I did a lot of checking for vitamin D in children, and I was amazed the number of positive tests, not just among Africans, but a lot of Asians as well. Unfortunately, the NHS would encourage parents to buy the vitamin D supplementation rather than prescribe. Now, have you got any comment on whether we need to supplement even pregnant women? Because there's a potential that when they are lacking vitamin D in their pregnancy, there is going to be a problem with the babies later.
Can I go on this?
Yes, Gideon, go ahead. Yeah.
So I echo what Dr. Aslam has said in terms of screening for diabetes. So in the UK, I've done antenatal clinics. I've done clinics with, as a combined antenatal with obstetrician. And the way we do is that, and the patient we screen for diabetes, if they're not diabetes, are those with previous big babies, more than 4 kilograms, macrosomic babies. If they had previous pregnancies where the babies were big, they have to be screened for diabetes. If they're ethnic minority, so African, Asian, regardless, we screen for them for diabetes. If they're white and they've got high BMI of more than 30, we screen for diabetes. That's the high BMI, being overweight before becoming pregnant, we screen for diabetes. But also first degree relative, whether you're white or other ethnicity, if you've got a first degree relative with diabetes, you have to screen for diabetes. I'm talking about screening for diabetes in pregnancy. In terms of vitamin supplementation, Dr. Aslam has talked about vitamin D. So from my limited experience in terms of looking after these patients who are pregnant or who are about to become pregnant, we give them, if a patient is about to become pregnant, if they're non-diabetic, they come to pre-pregnancy clinic. So we have to optimize their treatment. We have to make sure that their diabetes is well controlled. We put them on folic acid, the high dose of folic acid, which is 5 milligrams. Of course, we check other vitamins. So those who have got low vitamin D, most Asian or Africans, they've got low vitamin D. We give them the vitamin D3, pure vitamin D3, not that with calcium, just pure vitamin D3. They are given as a supplementation, make sure that it's optimized. So yes, I would say that if they've got low level of vitamin D, it should be supplemented with vitamin D during pregnancy. And if they are from high risk group, i.e. ethnic minority, such as Asian or African or Afro-Caribbean, they need to be given proper screening in terms of making sure that they don't get the so-called gestation diabetes or diabetes in pregnancy.
Yeah. Dugu, can I come in here? Excuse me, Chairman.
This is from your part of the world. I mean, I think you should answer this. Dr. Malwa, from your part of the world, and Tanzania, they're saying that can diabetes be reversed? And what is the implication and complication of taking metformin?
I'll try. Do you want me to go or wait for the other, for Dr. Caesar? Asai, you want to talk? Do you want to answer?
Yeah. The question I had was on vitamin D supplementations. Is the vitamin D in cereals sufficient? Because most cereals are fortified with vitamins, including vitamin D. Would that be sufficient?
So let me answer the first question from metformin, then I'll come to your question.
Okay.
So I'm going to answer the question of metformin.
Yes.
So the issue of can you reverse type 2 diabetes and what is the side effect of metformin? Is that right? That was a question.
Yeah.
So in terms of reversing type 2 diabetes, I talked about the modifiable risk factors. So modifiable risk factors being poor diet, lack of exercise, being overweight, having high cholesterol, having high blood pressure. So I've got 2 or 3 patients who I've been looking after. So if we get their diagnosis early, those who are aware, they modify their risk factor. For instance, they will come with a sugar level of 20. And we do something called HbA1c, which is a 3 months reading, average reading for their diabetes control. The patient I've had, if they are new, they modify the risk factors. Within 3 months, you get better reading. Some of them, they lose weight, they stop eating junky food, they exercise, and therefore, maybe they don't need any medication. Yes, you can reverse it. And there was a trial in Newcastle called Direct Trial, where I think it's a community-based trial by giving low-calorie diet to patients with type 2 diabetes, and they were reversing their diabetes. So, if somebody has been diabetic for 20 years, it will be difficult to reverse that. So in summary, you can reverse type 2 diabetes if it's a new diagnosis, and therefore the patient comply with modifiable risk factors. I cannot insist this more. Modifiable risk factors such as exercise, losing weight, eating healthy diet, controlling their blood pressure if they've got high blood pressure, controlling their cholesterol if they've got high cholesterol, stopping smoking, and eating healthy diet. In terms of side effect of metformin, so when I see my patient for the first time and I decide to put them on metformin, we know there are different side effects. The commonest one is the gastrointestinal side effect. So we tell them, because there are lay people who say that if you get tummy pain or abdominal pain and diarrhea, it can be a side effect of metformin, especially the normal metformin. And sometimes we've got modified or slow-release metformin, which is a gut-friendly. We tend to switch to that. And if they're not able to tolerate altogether, we stop it. So that's one of the side effects. The other side effect, which is rare, is metformin can cause malabsorption. So there was a study which was done in Holland, and even here with one of my junior doctor in terms of B12 deficiency. So there's a relationship between being on metformin long-term and the B12 deficiency. And therefore, as a part of annual review, we tend to check kidney function, cholesterol, B12, and folic acid as a part of that. But also we know that type 2 diabetes is an immune condition. If that's the case, you can go with other immune conditions such as B12 deficiency, which is called pernicious anemia. So that's a second side effect. The other side effect, which is very rare, is you can have very high lactate with metformin. So I was on call yesterday, and I had a patient who came, his type 2 diabetes, lactate was 70. The normal lactate is up to less than 2. So the question is, has he got high lactate because of metformin? Yes, we stopped metformin short term, but this patient came with abdominal pain, the other cause of high lactate. So in summary, there are 3 side effects of metformin, i.e. the causing diarrhea or abdominal pain, B12 deficiency, causing high lactate. But if somebody has got kidney problems, you can't give metformin. The contraindication for metformin in kidney disease is when you've got creatinine of more than 150 or eGFR of less than 30. So one has to be careful.
Now, from the southern part of Africa, I mean, the Botswana, I mean, they have asked, now, what is the role of bariatric surgery in reversing type 2?
Let me answer Dr. Caesar question. I'm going to answer that question. So yeah. Dr. Caesar asked about cereal, having fortified vitamin D. So the daily requirement for vitamin D for all of us is about 2,000 units. Okay, so I'm not sure. I'm not a dietitian, but I think that if it's based on that, what is in there, I think it might be enough based on how much is fortified within the cereals. But I'll say, in short, that we need about 2,000 units or 2,000 units per day as a normal requirement from nutrition. And when I see my patient with vitamin D deficiency, sometimes we give them about 1,000 to 2,000 units of vitamin D daily. But if you want to give them the loading dose, you can give up to 60,000 units per week for 12 weeks and you stop, especially for those who have got very low vitamin D.
Yeah.
And those who are not able to absorb, some people have got other problem with absorption, we give them injections, IM injection of vitamin D. I hope I've tried to answer the question for Dr.
Well,
Sid.
thank you very much. Yeah, I think you are, yeah.
Then the South African question, what was the question?
What is the role of bariatric surgery in the reversing type 2 diabetes?
Okay, so I've done obesity clinics as a part of a training in Southampton. So we used to learn obesity clinics, and also as a diabetologist, but also in Tooting St. George's, because I trained in both Wessex Deanery and London Deanery. So I'm going to share my experience in terms of which patient I've seen. So by bariatric surgery, it means weight reduction surgery. And there are 3 or 4 types of that. So one type was just putting you used to use a balloon. You put a balloon within the stomach for a few months. The patient feels that he's full, he doesn't eat, and therefore they lose weight. But also, there's gastric band, whereby you take a part of the stomach, they just try and squeeze the stomach to be small, and therefore the patient will be eating small amount of food, he feels full or she feels full. And with that, if you don't eat, you lose weight. If you lose weight, you get better diabetes control, you get better blood pressure control, you get better cholesterol control, especially the bad cholesterol will go down. But also, most radical part of bariatric surgery or weight reduction surgery, there's the so-called gastric bypass. So the gastric bypass, it means that you try and remove part of a big chunk of the stomach, then you leave a small part which will be connected to small intestine straight away. So the stomach being maybe this size will be just that small size. And with that, patients eat less and less. If they eat less, they will have better weight loss, okay? With that, it's a significant amount of weight loss. I've written case reports on weight loss and diabetes, both here in Queens. We wrote it last month. It's one of my case reports in Eurodiabetes, but also I wrote before. So I'll give you an example of my patient who was 150 kilo when he was seen 4 years ago. He's now about 90 kilo.
Yeah.
So that is the role of bariatric surgery. So it's good for a lot of things in terms of everything. But the patient, if they've got bariatric surgery, they tend to have malabsorption. So these patients are on vitamin supplement. So they'll be on vitamin D, they'll be on iron tablets, they'll be on vitamin B12 and vitamin D.
Thank you very much indeed, Dr. Malwa. And to the participant, I think we will try and summarize these lectures. We think it is very important. We will also try to summarize these lectures and make it available. And the slides will also be available. We will try and make sure that DHSP take care of you, because I know that many of the participants are finding the medical terms a bit mind-boggling, as one of them put it in the comment. But don't worry about that. We will try and see how it can be summarized in simple language. Now, James, I don't know whether His Excellency is ready to say maybe 1 or 2 words.
Okay, all right. Let me see. Yeah, I think I've just, I've made it to this. Yeah, there is.
Yeah. Hello. Good afternoon. Good evening, everyone.
I can hear you, but we can't see you yet.
You can't see me?
Not yet.
How did I log on?
Unmute your video.
Now, where is it now? Unmute the video. Where is it now?
The video is on your left side. It'll have a cross. Take away the cross.
It's technology thing.
Yeah, yeah. If you look down, if you wave your cursor on your screen, then something will come, and then on your left side you will see video. There's a microphone and a video on the left side. Then if you click on the video, probably then you unmute it.
Now, can you see me?
No, not yet.
No.
Okay.
We can see your presentation, Your Excellency.
Yeah.
You can see me?
We can see your presentation.
I don't have a presentation.
All
No.
right, okay. At least the name is on the screen.
Yeah. Talk, and then on your left side there should be a video.
Okay, let me see. Let's see.
So you unmute the video. James, can you see him? Can you try and unmute his video?
No, it is him who will have. I unmuted the voice. I cannot do the video. He has to do it by himself.
Yeah. It will be probably on the left side. Yeah.
Well,
Okay.
I can't get it. I can't see it.
Okay, don't worry then. I think you can just give us your address and then.
Yeah, you know, I joined using the software that you gave me, but always my video is displayed down here. But anyway, no problem. You can hear my voice.
Yes, we can. Yeah.
Well, I want to thank all of you for appearing on this important seminar. And most importantly, the person who invited me to make a small remark, my big brother, is it Nyero? Nyero Kobangole? Kopurpe.
Yeah, one take on.
Bear, and Mr. James Kilama-Oceng.
Yes, I'm here.
Yeah, 2 weeks ago when the advert was going on, I had to allay the fears of one of the technical presenters on this forum. He saw the name Bobby. I told him, the name Bobby is the name of a county in our country, Uganda. You know, Bobby is it a sub-county or a township?
It's a county, sub-county.
It's a sub-county. Yeah, it is bordering Oyam district. So we used to ride to Gulu via Bobby. You cannot go to Gulu unless you're past Bobby. So I told him it's the name of a place, not the name of a politician. So because he wanted to bolt out, I said, no, you stay on, hang on there because of the subject matter you're going to present. It concerns all of us. Well, with that small joke and intro, I am very impressed with this technical seminar. You have summarized a lot of medical courses in a very short time. Things to do with diabetes, which has just been presented by my good friend, Dr. Gideon. Things to do with mental health and a lot of other stuff. All these things affect us here in the UK, and they also affect our people in Africa, in Uganda, in Tanzania. As somebody has said, you should be more simpler in your presentation. There are a lot of FM stations in our countries. You can either sponsor programs or you call directly and you talk to people about the implications of some of the diseases and lifestyles that you have presented tonight. It can add value. I see from, by just direct observation, you are very senior citizens. And time is now ripe for you now to continue sharing your experiences with people around you first, and then with people in Africa through radio programs. I'm sure if you look around for some small grants, you can have some activities going down there in Uganda or in your respective countries, using simpler languages and descriptions and case studies that our people can kind of comprehend. In this way, you will be sharing your knowledge across the board in a very low-cost system. COVID-19 has brought a lot of complications for us. Many people live and stay indoors. People eat a lot of food, yeah? They build a lot of weight. They are not doing exercises. The sedentary lifestyle, as presented by Dr. Gideon, is also a contributing factor to diabetes condition 1. I followed all his slides, and he said diabetes is on the rise. Now, I am made to know that diabetes is one of the main causes of death. If there is a condition of disease and there's diabetes involved or inscribed in it, the patient finds it very difficult to recover. So, ladies and gentlemen, I just wanted to reassert that what you have presented affect all of us. Now you need to do more, a little bit more of societal intervention through communities and organizations around yourselves and also through radio programs. Because governments are working, but people need to listen more also to you. People are in Africa, they need to listen to your voice. If they hear from Dr. Christopher Nyeho, for example, if you can sponsor a program, a 1 hour or a 2 hour program, and you talk about the subject matter that you talked about to us in local language, it can add value, it can change the lives of people. In as far as laying of the fears against stigmatization on mental health is concerned, I think this is the only way you can reach the people in a cheaper way than you think. These are all my remarks. I thank you all. I thank all of you for appearing online today, and I thank everybody who has logged on.
Yeah, thank you very much.
Thank you. Thank you.
Very much. Yeah. Now, James, is Moses around?
Moses, unmute yourself.
Oh yeah, okay. Now Moses. I'm going to invite Moses, Moses, who is actually heading the Uganda-UK Health Alliance, and we are actually SDHSP and the Diaspora. We are members actually of Uganda-UK Alliance. Alliance. So Moses, can you say maybe 1 or 2 words?
Yes, thank you, my brother Peter, for inviting me and everyone here. Uganda UK Alliance, greetings from Professor Jade, who is very, very passionate. He wanted to be here today, but he was a bit busy this afternoon. Uganda UK Alliance itself is a body which brings together UK organizations and institutions, including diaspora organizations interested in supporting development activities in Uganda. So it also works both ways. Ugandan organizations working in UK. So we work together. And we see the diaspora as a key area of our work, and we're very keen to sort of work together. I think His Excellency sits on our executive board alongside other different individuals. We want to work closely with you guys. We want to work in the community initiatives around supporting the UK, bringing back learning from Uganda to the UK diaspora here. And you play a key part in this. So we're very appreciative. Professor Jade is very keen to be involved in going forward. He's actually, if you can invite him in the next sessions, he will be very happy to be here as well as our co-chair. I'm always happy to support as well. Thank you.
Thank you very much. Yeah. Thank you for that as well. Yeah, that's the beginning anyway, and it's also a learning curve, and it's a trial. And as His Excellency has also pointed out towards certain other avenues that we will explore. So we are very happy that, at least this meeting has been fruitful. Now, the panelists, is there something more we can add?
Yes, but can I just request the attendees, please? I'm going to send in another set of feedback. I think I need just to get it on, which I would like the people to fill in. The last feedback that we sent was actually the results. There were quite a number of people. I think we have about 30 people who responded within the 2 minutes. So I'll be sending one with regard to the diabetes now, as we go along. Thank you.
So how long does it take for the response to those feedback?
Well, it took, on average, it was 2. On average, it was 2 minutes.
Yeah.
So
now, is there, I can see that Dr. Malwa is still there. So is there any other question that was from the participant that we had overlooked?
So there's somebody who was asked about Ramadan and fasting and type 2 diabetes.
Okay. I think that is a good question as well. Very good, actually.
So I've done a study here called RADA, Ramadan Admission Rate Audit. We did it in Queens, because this area we are surrounded, we serve about 1 million population people around this area, but we got high numbers of Muslims. And in our study, we looked at what service do we offer to our patients with type 2 diabetes or type 1 diabetes, but who are Muslim in this area. So in that audit, we looked at that, but let me talk about the diabetes and fasting. So we know that fasting during Ramadan is one of the 5 pillars of Islam. I'm not a Muslim, but I have to read about that. And we know that is important for our colleagues who are, or our patients who are Muslims, and they need to fast. And therefore, the advice which is there in terms of that, because it's one of 5 pillars of Islam, you can only advise the patient. But we know that you can divide diabetic patient as high-risk patient. So those who are type 1 on insulin, they are high risk in that sense. Those who are type 2 taking insulin and also taking other tablets which can cause low sugar, they are high risk. But those who are type 2 diabetes just on diet, they can fast. So they're allowed to fast. And if a type 2 diabetes or type 1 diabetes patient who is Muslim decide to fast, we need to support them. The regime of their treatment is different. The days are changed upside down. It means that their night is a daytime and their daytime is nighttime. So we tend to support them. But the overall advice that we know that with fasting, there are a lot of risks doing that. One of them is dehydration, getting diabetes ketoacidosis, or other complications. But if they decide to fast, we support those patients to fast. And one idea which came out of RADA, or the so-called Ramadan and diabetes admission rate audit from my center, was that before Ramadan, we go and raise awareness. We work with the GPs, we work with imams in terms of just raising awareness that Ramadan is about to come. For those who are diabetic, the measures which need to be taken. If you decide to fast, we will support them. So the answer from the person, from Suleiman, he asked that question, that if you are type 2 diabetes, can you fast? Yes, if you are type 2 diabetes and you are not taking medications, you can fast. And if you are on medication, you can get support. So that question I was trying to answer because somebody has asked about fasting and type 2 diabetes, and I believe it's fasting, whether you are Muslim or not Muslim, it's important to get support from healthcare professionals.
Now,
the chairman.
Yes.
There was a question from somebody called Mr. Emmanuel Olal, something which I wanted to respond to. He's asking that he's a medical doctor studying at the London School of Hygiene and Tropical Medicine.
Yeah.
And he's asking if there are some activities that can support, his studies. And I think this is the kind of people we really want to work with. So
yes.
if James could take the contact so we can liaise with Mr. Olal, who is presently studying at the London School of Tropical Medicine in Hygiene.
Yeah. Yes, we want that. We want that kind of thing. Yes,
yeah.
James can take that. Okay. Is there any more?
Yes, please. I'm just going to put, while we are looking, I'm again putting the feedback. So
okay,
please, if you look at the chat, please.
Dr. Gideon, there is a question about whether diabetes can cause hallucinations.
Oh, yeah.
So we talked about acute complications of diabetes, as if somebody comes with acute complications, which we talked about, having very high sugar levels. For type 1, it's called diabetes ketoacidosis. For type 2, they got very high sugar levels, and sometimes they can come very just unwell for that matter. So if somebody is 70 years old, they come with infection, they come with other problems, and they've got a bit of dementia as a part of their problem. When they've got very high sugar levels, it makes things worse. They'll be more confused. Yes, they can hallucinate. So that's a central nervous system manifestation of very high sugar levels, which are poorly controlled.
There was one for Dr. Nyeko. Is dementia reversible?
Yes, I've spotted three other questions, but anyway, this is one of them which I was trying to answer. Right, so dementia, is it reversible? The situation where dementia can be reversible is when there's early diagnosis, where what have been causing the dementia can be reversed. So the commonest was like diet, toxins, inflammation, hormonal, repeated mini strokes. So if all those situations are corrected and the person improves the diet, exercises, modified toxins, we remove the toxins, we correct the hormonal imbalance. In that situation, with the very early diagnosis of dementia, it can be reversed. But in advanced dementia, where you have, like in Alzheimer's, with the one which have very heavy strokes, that one is very difficult to reverse. Right, the other two questions I saw from directly to me was about awareness of mental health in Uganda. What are we going to do about that? What the High Commissioner mentioned it briefly, that we should start having some session either on radio, television, WhatsApp, Zoom, so that the more we do and then target it with, including involving local radios in Uganda and television, so that we are addressing the population in Uganda and making awareness similar to what we have done today, but targeted. That in a way improving awareness, but also apart from the diaspora health strengthening Zoom, although I don't have the details, but that is one of the avenues that can be used. So to improve the, but also we have the health advisory, we have a WhatsApp where the staff, we can exchange ideas and improve the education system of medical students, nursing students, healthcare professionals. In that way, they are able to bring more awareness with the people in Uganda, especially northern Uganda. The other third question, which was raised, is update on COVID-19 vaccines. So that I mentioned that as part of good hope, good news. Although recently there has been hundreds of vaccines on being experimented and so on. But recently we have only 3 in England, which is one from Pfizer, Moderna, and the Oxford one with AstraZeneca. So this one, we need to, they still need to go through regulatory safety. So that one we are still waiting. So we need, because it's like medication. You need to go through rigorous regulatory monitoring before it's released. So I think the process at the moment.
I think one of the things, moderator, there's a lot of suspicion with regards to vaccines and so on. So we may actually need to have a separate session, just to talk about vaccines.
Yeah, that is exactly what happened, because Christopher, you remember you had a few slides on vaccines.
Yeah.
We removed it because of that.
Yeah.
That's a completely different topic.
So we may need to have a session really on
we'll
that.
Handle those. We'll handle. This is just the beginning. Yes. The panelists, I think, is there any more that we can, any more question that is hanging around?
I think maybe for information of His Excellencies that we did plan to do a feasibility study in northern Uganda, but then the COVID hit us. So the plan is still on the drawing board because travel became impossible.
Yeah.
But it is something that we may have to resurrect. Yeah.
Definitely.
Yeah.
Just
if I can make it.
And actually part of this program involve us contacting the media at home.
Yes, moderator, because when actually it's good that Dr. Nyeko kind of picked up on His Excellency's comment about linking up with those at home. There are a number of community-based small groups that are in direct contact with those in the villages and on the ground. So apart from media, we need to involve these groups so that they are the mouthpiece in terms of sustaining the messages that we will be passing on. I remember I've shared with Diaspora Health Strengthening Partnership some excellent work that a small group, Umoja Development Agency, did with regards to talking to people in the villages about their experience of COVID. And mental health came up as an issue, and also access to other services for managing their conditions. For example, people with diabetes have been seriously impacted upon. So those kind of the kind of messages that we have, if we can gear it and target those small community groups so that they can sustain the dissemination of the message, then I think we will be making a bit of a difference in people's lives.
Absolutely.
Okay, now James.
Yes.
Yes. James, I think we are thinking of almost winding up, but let's hear from Caesar first. Caesar, you were going to say something?
No, I think Alfred has summed it quite well. Yeah.
Yeah, summed it. Okay.
Yeah.
How about you, Charles?
Yeah, I think the most important thing is actually impressed by the excitement that this first program has shown. I just want to say that this is a beginning and we are going to roll this one on.
Yes.
So the next program is probably not purely diabetes or mental health, but all other aspects of health. Now, when we talk about the connection with the radio program back home, we've already talked about this, and it's got to be.
Go ahead.
Yeah, so with the translation and so on, our doctors back home who speak Acholi and so on, or let's say Luo, because Acholi, Langi speak Lao. Let's talk about Luo speakers to help with the program of translation, so that we got a vocabulary of Luo medical terms that we can refer to, so that when translation is done on the local radio, it's easily picked up and understandable.
Okay.
I think if Professor was here, he would have a different view. He did raise the question that there is a language unit in Makerere University that we could actually liaise with. They would probably do.
Those. We are not going yet to do anything yet until we have got all the avenues. Yeah.
Yeah. Can I just raise one thing? Apart from the feedback that we have sent, DACP is also opening itself up for admitting members who would like to volunteer. So there's a link which I'm going to send now, and if you would like to volunteer or joining DACP, you can always, if that link, you'll give us some of the details and we'll get back to you. So there's a link which I've just sent just now.
Okay. So can we wind up the webinar now?
Yes. That will be proper.
This webinar will be put also on YouTube.
YouTube, yeah.
Those who have not been able to, or those who would like to use it again anyway.
Yeah. Okay, I should
Thank you very much, everybody.
Thank you. Yeah. I should thank all the panelists for participating. And most of all, I would want to thank the participants from home, because I will know how difficult it is with the facilities at home to join a webinar. And I would also want to give special thank you to His Excellency, the High Commissioner, for joining us, and Moses from Uganda-UK Health Alliance for joining us. Now, this webinar is recorded. So for many purposes, first of all, we will need to, a certain version, we may put them on YouTube, but we may want to see it as a sort of data where we could do a lot of translation for dissemination of information to the rest of the community. So thank you very much indeed. Remember, you can still go to DSSP and join the membership, or you can use our info email and propose topics or whatever other things that you want to discuss. Thank you very much.
Just a reminder, the recording is, as far as the video is concerned, is only on the panelists and those who have talked. So the attendees, we don't be
expecting it. Yeah, okay.
So you're not on the screen.
Yeah, okay.
No.
All right.
All right, thank you.
We can then finish the meeting. Thank you very much for participating.